We often think about childhood accidents as, minor things, scrapes, bumps, maybe a broken bone from the
All
playground.
the usual stuff.
But there's this less common, but incredibly serious issue: vascular injuries in children.
Yeah.
And get this, trauma is actually the leading cause of death for kids over 1 year old in the U.S.
It's a sobering statistic.
Yeah.
It really puts things into perspective, doesn't it?
Mm-hmm.
We focus so much on everyday safety, which is vital, but understanding these, well, rarer vascular traumas
Yeah.
is crucial for those moments when they do happen.
Exactly. And that's what we're digging into today: pediatric vascular trauma. We're using Rutherford's vascular surgery and endovascular therapy as our guide, specifically the chapter on this exact topic.
It's a fantastic resource.
Think of this as like your quick guide to understanding the causes, how they're diagnosed, and the strategies for managing these injuries.
And our mission here is really to pull out the key insights, always keeping in mind, the unique challenges of treating kids, treating growing bodies.
Right. And we'll look at two main types. First, iatrogenic injuries. Those are the ones that are kind of surprisingly happen because of medical procedures.
Yeah, that's a big category.
And second, non-iatrogenic injuries, the ones from external trauma, like accidents.
And it's worth stressing, while these injuries aren't super common, maybe less than 1% of pediatric trauma cases, the potential outcomes are so serious, they're a major concern.
Okay, so let's start with those iatrogenic injuries, the ones that happen during medical care. Now, you probably think accidents are the main thing, but what really jumped out at me was how common these iatrogenic ones can be.
Mm-hmm.
I mean, some children's hospitals report they make up like all of their pediatric vascular trauma cases.
100%. It's a striking figure. It really is. It just shows how careful we need to be, even with seemingly routine things in these tiny patients.
Yeah, it makes you think about training protocols.
It's a stark reminder, isn't it? That even with the best medical intentions, there are risks, especially for the very young.
Mm-hmm.
And these injuries, they pop up in a surprisingly wide range of situations.
Can you give us some specific examples just to paint a picture?
Sure. Think about putting in an IV line. Seems simple, right? Or an arterial puncture to get blood gas samples.
Oh, yeah.
Then there are more complex things like transfemoral procedures, going through the leg artery for tests or treatments, even placing an umbilical catheter in a newborn.
Right.
And surgery, of course, open heart surgery with bypass, certain orthopedic operations.
Yeah.
Vascular damage can happen unintentionally.
So really across the board in medical interactions. And it sounds like the child's age plays a big role.
Oh, absolutely.
Mm-hmm.
The data is pretty clear. Newborns, sadly, have the highest rates of these iatrogenic injuries.
Mm-hmm.
Then it tends to drop as kids get older. Maybe half occur between ages 2 and 6. And then it falls again, maybe a third in kids over 6.
That makes sense. Smaller vessels, trickier access in infants.
Exactly. Their anatomy is just so delicate.
Yeah. Now, the source mentions specific risk factors for femoral complications from Lynn and colleagues. What did they find?
Yeah, Lynn's team highlighted 4 key things. Age under 3 is one.
Okay.
The specific type of intervention being done matters.
Yeah.
Also, having had 3 or more previous catheterisations in that same spot.
Repeated access.
Right. And using larger guide catheters,
Yeah.
specifically 6 French or bigger. Now, the wider the tube, the higher the risk in these small vessels. It helps clinicians flag higher risk patients.
So even when you take precautions like using heparin to prevent clots, choosing the right size catheter, the risk isn't zero. This source mentioned quite a range for thrombosis rates.
That's right. Even with those measures, clots can still form. The rates vary maybe from 1% up to like 25%.
Wow, that's a big range.
It is. It probably depends on the patient's health, the procedure, which vessel, artery, or vein, lots of factors.
And there was that really unusual example for treating a severe complication in newborns: leech therapy. That sounds pretty wild. Yeah.
It does, doesn't it? The source mentioned a case where leeches were actually used successfully for something called phlegmasia cerulea dolens.
Okay, what's that?
It's a really severe vein blockage in the leg. So bad it can cut off blood supply, turns the leg blue. This was in newborns after a procedure.
Wow.
Definitely not standard practice, but it just highlights the complexities. Sometimes you have to consider really unusual approaches in these tough cases.
Fascinating. Okay, let's switch gears. Non-iatrogenic injuries. The ones from external trauma. These get more common as kids get older, right? Past age 6.
That's a general trend, yeah. Kids get more mobile, more active, and unfortunately the risk of accidents goes up. But how these injuries happen can be really different depending on the circumstances.
How so? What influences the injury type?
Well, think about conflict zones. Tragically different situation.
Right.
Kids there face high-energy penetrating injuries, gunshot wounds, IEDs. These are often incredibly complex, damaging vessels, bones, soft tissue.
Devastating. And what about here in the U.S. in peacetime? What are the main causes?
Motor vehicle accidents. They're the top cause of overall trauma in kids, and a big driver of these vascular injuries, too.
Huh.
After car crashes, you see firearms, stabbings, falls. It's interesting, though. Overall, blunt injuries are the most common type of trauma in kids here.
Right.
But if you look specifically at non-iatrogenic vascular injuries in kids over 6, recent studies often find penetrating injuries are actually more frequent in that specific group.
That's an important distinction. And the severity. How do blunt versus penetrating compare?
The data suggests kids with blunt injuries tend to have higher overall injury severity scores.
Why is that?
It might be because blunt trauma often involves, a wider energy transfer, affects more body systems.
Okay. Now, location. Where do these non-iatrogenic injuries usually happen in the body?
Overall, the upper extremities, arms, hands are the most common spot.
Makes sense. Arms are out there exposed in falls and things.
Exactly. But, and this is crucial, injuries in certain other areas carry much higher risks.
Right. I remember reading that. Which areas?
The trunk, so neck, chest, abdomen. Vascular injuries there have the highest mortality rates, sometimes over 50%.
50%? Wow.
Yeah, it's usually because they often come with major damage to vital organs. That drives up the overall injury severity.
And what about veins? Are venous injuries common as dangerous?
They're generally less common than arterial ones in kids.
Yeah.
And they can be harder to spot, actually, so there's less specific research on them.
Okay.
But when you have both an artery and a vein injured, the risk of death goes way up. For location, the IVC, the big vein bringing blood from the lower body, that's the most hit, truncal vein, and IVC injuries, very high mortality.
And in the limbs?
The femoral vein in the leg is the most common extremity vein injured.
So less common, but still really serious, especially major veins like the IVC. Okay, let's talk about the specific anatomical and physiological stuff that makes pediatric vascular trauma different. We mentioned vessel size, but what else?
A key thing is anatomical landmarks, the ones we use in adults to find vessels, not as reliable in kids. And that contributes a lot to those iatrogenic injuries we talked about. Like in the groin, the femoral vein and artery overlap quite a bit. In kids, 12%, maybe up to 33%.
That much.
Yeah. So if you're trying to access the vein without ultrasound, you've got a real chance of hitting the artery by mistake.
That really makes the case for using ultrasound more routinely in kids, doesn't it?
It really does. We know it helps reduce complications in adults.
Yeah.
Logically, it should help in kids, too, by letting you see the vessels directly. We need more pediatric-specific data, but it seems like a very strong possibility.
Definitely. Okay, vessel size again. How does that directly impact procedures?
Well, it's critical. Studies show a clear link between a child's femoral artery size and their weight or body surface area.
Right.
So picking the right size catheter, the right device, is absolutely essential to avoid things like spasm or clots. There's even a risk score for cardiac cath complications.
What does it flag?
Younger age under 30 days, lower weight under 2.5 kilos, and procedures needing larger sheaths, those introducer tubes, all high-risk factors for vascular injury.
So tiny babies, bigger devices, risky combo. And you mentioned arterial spasm earlier. Why is that such a big deal in kids?
Their vessels are smaller, yes, but they're also just more reactive, more twitchy, you could say.
Okay.
So even minor irritation from a catheter can trigger this intense, prolonged tightening vasoconstriction. It can even lead to a clot forming and completely blocking flow.
Wow.
Research shows the catheter size relative to the artery diameter is key. If the catheter takes up too much space or the size difference is really small, spasm is much more likely. It can even cause total occlusion.
A delicate balance indeed.
Right.
Are there other physiological things in kids that raise the risk of clots after an injury?
Yes. Low intravascular volume, basically, dehydration or less fluid circulating is a risk factor,
Okay.
and underlying medical conditions. Kids needing cardiac caths often have low cardiac output, meaning weaker blood flow overall, which also ups the thrombosis risk.
So it's the vessel size, their reactivity, and their general physiological state all playing a part. Now, the immediate results of a vascular injury, what happens?
You basically get disruption, a tear, or obstruction, a blockage,
Right.
or that spasm we talked about.
Right.
Obstruction means ischemia, lack of blood flow downstream. That needs urgent attention. If it's mainly vasospasm, the first step is usually removing the cause, like the catheter, and giving supportive care, maybe warming the limb, letting the artery relax.
And if it doesn't relax?
Then you might consider vasodilator drugs or more aggressive warming.
Okay. You mentioned a specific injury earlier, the brachial artery injury after an elbow fracture, supracondylar fracture. What's special there?
Yeah, that's pretty common. Kid falls on an outstretched hand, breaks the elbow, and sometimes stretches or bumps the brachial artery in the upper arm.
Okay.
Spasm is often the cause of reduced blood flow initially, but frequently, once the bone is set correctly, the blood flow improves on its own. So unless it's severe ischemia, observation might be okay.
Interesting. And what about those traumatic arteriovenous fistulas, AVFs? What are they?
An AVF is an abnormal connection between an artery and a vein caused by trauma. Could be iatrogenic or external. Sometimes they don't cause symptoms right away, so they get missed. But later, they can cause big problems.
Like what?
Like high-output heart failure, because the heart's pumping extra blood through the fistula, venous ulcers from high pressure in the veins, or even arterial ulcers from stealing blood flow. And sometimes the limb with the AVF grows bigger than the other one.
Limb overgrowth. Wow.
Yeah. But the good news is, once found, most can be treated, often minimally invasively, by ligating them or using coils to block them off.
So a localized injury can have really widespread effects. Okay, let's move to diagnosis. You said blunt injuries can be tricky.
Right. Penetrating injuries often have those hard signs, obvious bleeding, rapidly growing hematoma. Makes diagnosis easier.
All right, good.
Blunt injuries, much tougher, need a high index of suspicion, a really careful vascular exam.
What does that exam involve in a child?
Same basics as adults. Skin color, capillary refill time, checking pulses in both limbs, comparing them.
But you mentioned spasm complicates things.
Exactly. Trauma, even without direct vessel injury, can cause significant spasm in kids. That alone can weaken or eliminate a pulse. So a weak pulse doesn't automatically mean the vessel's torn or blocked. Surgery sometimes finds spasm was the only issue.
Definitely complicates things. So in a kid with multiple injuries but no obvious hard signs, what's the first step?
Priority one is always life-threatening injuries. Stabilize the child first.
Right.
That includes resuscitation, warming them up if they're cold. Then, once they're more stable, you reevaluate the pulses carefully. This avoids jumping to tests or surgery just because of spasm from shock or cold.
Stabilize first, then investigate. Makes sense. What about using handheld Doppler for serial exams?
Very useful if there are no hard signs. The Doppler can pick up blood flow even if you can't feel a pulse.
Okay.
And you can use it to calculate the ankle brachial index, the ABI, comparing ankle pressure to arm pressure.
But you said ABI has limitations in young kids.
It does. Under age 2, it's not as reliable. Their normal ABI can be lower than the adult standard of 1.3.
So what do you use instead?
The Injured Extremity Index, or IEI. You compare the Doppler pressure in the injured limb to an uninjured limb. There are specific cutoff values for that.
Got it.
And pulse oximetry measuring oxygen saturation can also be a good, non-invasive way to monitor arterial flow, especially in situations like that brachial artery injury.
So physical exam, Doppler checks. What about actual imaging? When do you need scans?
If, after stabilizing the child, warming them, fixing any fractures, you still have concerns about blood flow to a limb, then imaging is needed.
What's the first choice?
Often duplex ultrasound. It's very accurate for finding arterial injuries, shows real-time flow. But its usefulness depends on the injury location and operator skill. Great for neck arteries, maybe less so deep in the chest or abdomen.
And CT angiography, CTA.
CTA is really reliable for blunt torso injuries if there's a seatbelt sign, for example.
Okay.
And it's great in multiply injured patients, might pick up hidden truncal vessel injuries. Plus, it works well for extremity arteries in kids of all sizes.
Seems like CTA gives a bigger picture, especially in complex cases. When would you need traditional angiography?
That's usually a last resort in kids. Radiation, sedation risks.
Right.
But it can be definitive for pinpointing the injury location and sometimes helps tell the difference between a real injury and just severe spasm.
So weigh the risks and benefits and the bottom line on diagnosis.
The bottom line is this. If your tests are inconclusive, but the clinical signs point strongly to poor limb perfusion, you go to surgical exploration. Regardless of age or size, you can't wait and risk the limb.
Right, absolutely. Okay, let's talk management. Requires a team effort, I imagine.
Totally coordinated. Survival is goal number one. And a lot of the adult vascular trauma principles apply.
Like the priorities in the OR.
Yep. Exposure, hemorrhage control, restoring flow.
Yeah.
The basics. And we use similar adjuncts, tools, and techniques.
Tell us about those key adjuncts.
Okay, temporary vascular shunts. Really useful.
So-so.
They buy you time. Reduce ischemia time, how long the tissue is without blood, while you fix other major injuries. Minimizes nerve damage, muscle loss, compartment syndrome.
How do they work?
You put a temporary tube in the artery after clearing clots downstream and flushing with heparinized saline. You can even use things like pediatric feeding tubes sometimes.
Resourceful and heparin, the blood thinner.
Big role. As long as there are no contraindications like major bleeding elsewhere, it prevents platelets clumping, stops clots growing.
Okay.
Can even help in spasm cases, maybe keeps the vessel from totally clotting off.
Yeah.
So systemic heparin is pretty standard unless there's a reason not to give it.
Now, managing without surgery, that seems counterintuitive for an artery injury. When is that okay?
In adults, sometimes minor arterial tears seen on imaging where flow isn't totally blocked are watched closely. If the limb perfusion stays good,
Right.
the idea is small intimal injuries might heal on their own. We apply this cautiously in kids, but it requires very close monitoring, repeat imaging. You have to be sure it's not worsening.
And what about leg artery injuries in infants and toddlers? You mentioned the historical approach was changing.
Yeah, historically, people were hesitant to operate early unless there was major bleeding. They might ligate, tie off the vessel, or just use heparin and watch.
Why the change?
Because we realized the long-term outcomes weren't great. Limb-length discrepancies, abnormal growth from AVFs, even late amputations.
Ah,
So now there's a push towards more aggressive exploration, even if you suspect spasm is the main issue. It's technically tough on tiny spastic vessels, and you have to think about future growth.
so earlier intervention is often better now.
Generally, yes.
Hmm.
Though recent data suggests maybe for truncal ischemia in the really young, anticoagulation alone might be okay initially in select cases, with super close monitoring via duplex ultrasound. But if things worsen, you explore surgically, regardless of size.
A complex calculation. Any other adult adjuncts relevant in kids?
Definitely. Liberal use of fasciotomies releasing compartment pressure is critical for limb salvage, especially in the legs.
Right.
And endovascular techniques, balloon occlusion for bleeding, restoring flow, are valuable when the vessel size allows.
Okay, let's zoom in on managing those iatrogenic injuries. Any specific considerations there?
They can cause partial or complete blockage. Complete occlusion means rapid limb ischemia.
And the timing is critical.
In adults, there's that ischemic threshold. But there's some evidence kids under 2 might actually do better with early exploration, clot removal, and repair, even with complete occlusion. Potentially better tolerance or recovery.
That's encouraging. What if the iatrogenic injury isn't a complete blockage?
If perfusion is still good, maybe delayed repair is an option. Close observation, heparin. But if perfusion starts to decline, you operate. Immediate restoration of flow is always the gold standard, really.
Got it. You also flagged ECMO cannulation as a common cause.
Yeah, ECMO, the heart-lung bypass machine. Putting in those large cannulas, usually in the femoral or carotid artery, causes a significant number of iatrogenic injuries in pediatric centers. And needing ECMO itself is a risk factor for worse outcomes after surgery for limb ischemia, and specifically carotid injuries from ECMO, linked to cognitive issues later.
So what's the approach?
Some centers now routinely reconstruct the carotid artery after ECMO, and the results seem good long-term. Proactive repair is important.
Makes sense for long-term well-being. Okay, let's switch back to non-iatrogenic injuries in detail. Depends on location and mechanism, you said.
Exactly. Penetrating trauma object goes and priorities are stop the bleeding, fix the vessel, save life and limb.
Right.
High-energy injuries, like from blasts. Need extensive debridement, maybe shunts, liberal fasciotomy team approach. Wartime experience really pushed for early, aggressive surgical management.
And the actual artery repair in kids, different from adults.
Principles are similar. Small tear, direct suture repair, usually interrupted non-absorbable stitches. Bigger sidewall injury, patch angioplasty, often using a piece of the kid's own leg vein, the saphenous vein, to avoid narrowing as they grow.
And if you need to replace a whole segment, interposition grafts.
Right. Need to bridge a gap. Lots to consider.
Yeah.
How you sew it, anastomosis technique, suture type, graft material. Goal is accommodating future growth, preventing narrowing.
Suture technique matters for growth.
Theoretically, yes. Running sutures, common in adults, might act like a purse string, restricting growth. Some favor interrupted sutures based on animal studies suggesting less narrowing and maybe less clotting with non-absorbable ones. Saphenous vein is usually the preferred graft material, durable. Shunts are key here too in complex cases, like bad dog bites or combat injuries needing big debridements before grafting.
And you keep mentioning fasciotomy for lower leg injuries.
Absolutely critical.
Yeah.
Early, liberal four-compartment fasciotomy significantly improves limb salvage chances by preventing compartment syndrome. Standard in military trauma, essential in civilian pediatrics too.
Okay, let's revisit that blunt brachial artery injury with the elbow fracture. Seems really common.
It is. Upper extremity arterial trauma is the most common overall, often with ortho injuries. Most improve just by fixing the fracture. But that specific injury, fall on outstretched hand, supracondylar fracture, can injure the brachial artery. Happens maybe 10% of the time, often with nerve injury too.
How does it present?
Can range from normal looking to a pulseless pink hand. Looks okay, but no pulse to severe ischemia, usually caused by artery stretch or compression.
And the management controversy was around that pulseless pink hand.
Exactly. PPH after fracture reduction. Historically, many watched and waited with anticoagulation, only operating if it got worse. Others argued for exploring the artery routinely.
What's the thinking now?
Well, large database studies suggest maybe outcomes aren't hugely different between observation and exploration for isolated injuries, but those studies have limits. Newer case series show many PPH patients regain pulses after reduction. So the current lean is towards conservative management for PPH anticoagulation, close watching but urgent surgery if perfusion worsens.
But if the hand is cold and white...
Cold, white, pulseless hand after reduction, that needs immediate exploration and repair, no question.
Clear distinction there. Okay, truncal injuries. Neck, chest, abdomen, you said highly lethal.
Extremely. Overall pediatric vascular trauma mortality is maybe 8–13%, but for truncal arterial injuries, much higher. Neck around 16%, chest over 40%, abdomen 25%.
Wow.
And most deaths from pediatric vascular trauma involve these isolated neck and trunk vessel injuries. Hemodynamic stability on arrival is the biggest predictor of outcome. That plus IVC injuries, location, mechanism.
What about blunt aortic injuries in kids, less common than adults?
Much less common and usually fatal. Takes massive force, often to other severe injuries too. Seatbelts and car seats have likely helped reduce these.
How are these truncal injuries managed? More open surgery?
Mostly, yes, especially the aorta. Endovascular options are limited by vessel size. Most thoracic aorta injuries need open clamp and sew repair. Survival is decent if they're stable initially.
Is delayed repair ever an option?
Yes. Similar to adults, delaying repair for blunt thoracic aorta injuries with beta blockers can improve outcomes sometimes. Small thoracic stents are used cautiously in some adolescents, but long-term data is sparse.
And abdominal or neck injuries?
Abdominal management depends on stability. Other injuries ranges from suture repair to synthetic grafts for aorta cava or using the kid's own vein or artery for other vessels. Neck injuries depend on the zone. Middle zone penetrating might be direct repair graft. Lower zone near chest might need sternotomy. Upper zone might be ligation or endovascular coil stents. Blunt carotid injuries are tough, rarely surgical, often managed with observation, antiplatelets, imaging. Innominate subclavian often need open surgery, though endovascular balloon control is emerging.
So mostly open, but endovascular is creeping in where possible. Let's talk more broadly about endovascular's role.
Still challenging in kids. Small vessels, current stent grafts aren't ideal for growth, so its role is increasing but still limited, mainly to adolescents.
What are some examples of use?
Controlling bleeding with proximal balloons, embolizing hard-to-reach bleeders, like high in the neck. There are case reports of covered stents for traumatic brain vessel injuries.
Is usage growing?
Yes, significantly. One study showed a threefold increase from 2007 to 2015, especially for thoracic, abdominal, pelvic, and upper extremity injuries. As the tech gets better, smaller, its role will likely expand quite a bit.
Promising for less invasive options. Okay, post-op care. What's key after the repair?
Close teamwork with pediatric specialists is vital for general care. For the vascular side, frequent hourly circulation checks. Any change needs immediate attention.
Medications.
Antiplatelet therapy, like aspirin, is usually recommended if there are no contraindications. Evidence isn't super strong in kids, but the thinking is it might help the repair heal, reduce early clotting risk, usually just for about 30 days. Routine anticoagulation, stronger blood thinners, generally not needed, and adds bleeding risk.
And long-term follow-up after discharge.
Tailored to the repair. Simple pulse checks, or IEI, for leg repairs initially. Duplex ultrasound surveillance at 1 month, then regularly, is good practice to check for narrowing aneurysms later on.
Any specific imaging needed long-term?
For thoracic aortic stent repairs, annual CTA scans until adulthood are usually recommended. Otherwise, routine CT-CTA isn't generally indicated for most repairs.
Assessing long-term outcomes sounds tricky.
It is. Kids can be hard to follow up long-term, and the case numbers are low, so we rely a lot on retrospective series, database studies.
What do those show generally?
In-hospital mortality, around 8–13%, as we said. Highest in infants and chest injuries. Amputation rates are low overall, but highest for brachial and popliteal artery injuries. Long-term studies on iatrogenic injuries show surgical repair is good at preventing limb loss, but some with chronic flow issues might have gait problems.
So survival is improving, but long-term function needs monitoring. Okay, let's wrap up. Key conclusions, future directions.
Well, a key point is that various specialists manage these rare injuries, and vascular surgeons see only a fraction. Because it's rare, we lack clear guidelines. Practice is based on animal studies, case series, expert opinion.
So what's needed?
Each hospital needs its own protocols involving all the specialists based on the best available data. We desperately need dedicated pediatric vascular trauma registries to collect better data on injuries, outcomes, long-term follow-up, including those neonatal iatrogenic injuries. Collaboration between registries, including military data, would be huge.
And ultrasound.
Its proven benefit in adults strongly suggests we need to investigate its expanded use in pediatrics more formally.
And the overall approach?
The trend, based on modern data, supports an aggressive operative management approach, much like adult trauma care. Multidisciplinary team, control bleeding, use shunts, liberal fasciotomy for legs, and increasingly endovascular techniques. Future research needs to focus on creating endovascular tools specifically for kids small size, accommodating growth both for preventing and treating these injuries.
This has been incredibly insightful, a real deep dive into a complex, critical area. So, to quickly summarize, pediatric vascular injuries, whether from medical procedures or accidents, pose unique diagnostic and treatment challenges due to growth and development.
Absolutely.
And the management is evolving, definitely shifting towards more aggressive intervention in many cases to improve both immediate survival and long-term function.
And that specialized knowledge, that multidisciplinary team approach, you just can't overstate how crucial that is for these kids.
Right. So here's a final thought for you, the listener. With all these advances in open surgery and endovascular tech, what will pediatric vascular trauma care look like in, say, the next 10 years? How might we see minimally invasive options truly tailored for growing children, addressing both the injury and their long-term needs? It's definitely a space to watch for innovation. Thanks for joining us for this deep dive.